Dr. Loh Wann Jia, who's a consultant endocrinologist from Changi General Hospital. She's also the co-lead of the Specialist Diabetes Care Center, the Sing Health Duke NUS Diabetes Center. And her topic will be lowering lipids with medications. It's 2024 and what we have now in modern science, like what Dr. Natalie Koh said. Here you go, Dr.
Thank you for the kind introduction. So my name is Loh Wann Jia. I'm very excited to be here. Thank you to Heart Center for inviting me. So I set up a lipid clinic about 5 years ago in Changi Hospital. This is to address this area of hypercholesterolemia and also the other lipid particles that Dr. Koh has nicely summarized for us. Now, I call this title is 2024. And the reason is because so many things have changed in the last 2 decades. I have to update you about it. Now, before we go into medications, let's think about Titanic first, right? So what happened in Titanic? Why did it sink? Well, it's because when we can see above the water, the iceberg looks fine, but how low does the iceberg go and how far and deep it is? And that's what we think about every day in our clinic, in our ward rounds, when we see about patient who has asymptomatic or people who have symptoms, actually how bad is the cholesterol plaques in the arteries. That could be also to the brain, so that can cause a stroke if that breaks, or to the heart, or even to the legs and cause ischemic legs and gangrene. But what really forms this plaque here are actually the cholesterols, and what carries cholesterols are lipid particles. So that's why I termed the title to be lipid-lowering medications. And rather than blaming the cholesterol, we need to look at what is the carriers of this cholesterol. Now, lipid particles carry cholesterol. All humans have this. We have the good ones, the HDL, as Dr. Koh has said, and the bad ones. There are many, many forms, but the ones that you need to know is LDL, because that's the most abundant one. And then there's also Lp(a), but not really going to address this today, but it's also important and common high cholesterol that we all carry. And there'll be further talks about this in future. So how to have a happy, healthy artery, right? Well, first, right, we need to lower all the bad forms of lipid particles that carries the cholesterol. And to do that, the most important thing, as we all doctors always say, is you need to have a healthy, happy life by eating healthy and exercise. You should start young, and that is a long-term investment. No smoking, reducing excess weight, blood pressure, sugar. And a common risk factor currently is actually high stress and poor sleep. So all this is really important. And if you do that, right, you can actually lower your bad cholesterol, but a lot of people, especially when we get older, it's not enough. We often have to consider whether there's a need for medications. Let's go back, right, to year 2000, right? To appreciate what we have now, let's see the journey of what medicine has happened. So in the year 2000, I remember, buying Nokia, and it's like so exciting. And then a Sony Ericsson with music, and then the iPod, and then iMac. But in year 2000, number one killer was actually heart attack. And the people who are young, which is defined as less than 65 years old, heart attack occurs in 83 people per 100,000 of Singaporeans. What is really scary is 1 in 4 will die within 1 month of having a heart attack. So it was a major killer. And at that time, in year 2000, all we had was statin. It was a great discovery. Statin was really, really important because it saved a lot of people's lives. And we see in 2010 and 2020, the number of heart attacks has continued to rise in Singapore. This is very important because, again, we're talking about something that potentially is preventable. The population gets older and the patient gets bigger, and hence the number does rise. But the good news is that the number of heart attacks that cause death within 1 month has dropped a lot with the help of medications. So not just cholesterol-lowering medications, but also diabetes and blood thinners and blood pressures and smoking and things like that. But with regards to medications that lowers the lipid particle LDL, we have statins. By 2010, there was only one additional player, which is ezetimibe, a tablet a day. And then by 2020, we have injectables. And I'll go more about this in the next few slides to explain to you how it works. So I think about it as the classes of medications, where they work, and then that may actually explain a bit further how come it's effective. So first in the liver, and secondly in the intestine. In the liver, we have statin group, and then we have the injectables. These injectables are aiming towards this enzyme called PCSK9. In the intestine, we have the ezetimibe, and we have bile acid sequestrants, so bile acid binders. If you have to compare which one works better, it's actually the agents that work at the liver. Talk about statin first. The real medical term is called HMG-CoA reductase inhibitor. So this enzyme inhibitor is very hard to pronounce, right? So let's just call statin. Now, statin lowers LDL by 30 to 50%. So if you're 5 millimole per liter, it tends to go down to 2.5 to 3.5 millimole per liter, depending on the dose or the type that you use. Why is it important to address statin in the liver? Because actually when we have sugar, the glucose is converted to cholesterol by the liver. And HNG-CoA reductase inhibitor, so you block the rate limiting step here, you will have less cholesterol being made. Statin also works by clearing cholesterol from the blood through the liver. And there are various forms of statin. Actually, medicine is not that difficult because actually we try to make it as simple as possible. So atorvastatin, rosuvastatin, anything that ends with statin behind is a statin. And the more commonly used one currently is atorvastatin and rosuvastatin compared with the older ones. The newer ones have actually better side effect profile and actually more effective. Next is the very exciting injectables. So the medical term is called PCSK9 inhibitors. So we have a few of this. Let's talk about how it works first. So remember I said, right, there's cholesterol plaques, and then what brings those cholesterol are lipid particles. We want to lower the number of lipid particles, LDL, and the clearance is through LDL receptors, this little pink color thing. So this LDL receptors clears the LDL, goes to the liver and throws it away. But what clears LDL receptor is the enzyme called PCSK9. The medical term is very long, and so you don't need to know that. But if we can actually lower the number of PCSK9 enzyme by using an inhibitor, we will have more LDL receptors and we can clear more LDL. So what we eat or what we make can be cleared. And that's the amazing discovery in the last 5 to 10 years. These agents can lower LDL by additional 50% on top of statin. And this is how they look like. They are actually injectables or a pen form, actually quite similar to how insulin looks like currently. So on the left side, we have two brands. One is Repatha or evolocumab, and another one is Praluent or alirocumab. The government has subsidized the first one, Repatha, so the cost has dropped a lot, and hence currently this is a more widely prescribed compared to the others. It's every 2 weekly self-injection, so you just pinch your skin and it goes in. It's not that scary after you try it one time. So then the other one on the right side is inclisiran. Now inclisiran or Leqvio is every 6 months injection. It's injected by a doctor or nurse. Slightly more expensive, but actually works very well and both have very little side effects. Now we come to the intestine, right? So we have two classes here, ezetimibe and the bile acid binders. So ezetimibe lowers LDL by 15-25%. Why is this? Well, because we want to aim at the intestine. If you think about where the majority of our fat and cholesterol comes from our diet. So, for example, yesterday I ate fried char kway teow, and then you see this high cholesterol and triglyceride floating around in my intestine, right, in the stomach. This will become a micelle. So these are lipid droplets, which will then go through intestine to be absorbed through the transporters, so in other words, doors. And if you can spot that NPC1L1, that's the transporter or door into the intestine. And ezetimibe blocks that, and hence it reduces LDL cholesterol absorption into our blood by 15-25%. Come to the fourth class, perhaps the weakest one, but it's still quite good to know about it because actually this is actually safe in pregnancy. So bile acid secretins or bile acid binders, the examples are cholestyramine or cholesyvalam. So you see, right, coming back again to what we eat, is absorbed in our stomach, goes to the intestine, and the bile acid binders will actually block this lipid formation and therefore reduce formation in intestine. It also blocks the transport into the intestine, and that's how it lowers LDL by 10-20%. I keep saying the word inhibitors, I keep saying the word blockers, actually they mean the same thing. And actually you can see for the last few minutes, what I've been trying to say is how we tend to improve our LDL status is actually by blocking the things that make it or blocking the things that break the things that clear it. So it's usually through these pathways that it works. And what's really interesting about this is they are working through different pathways and therefore different organs, so the lipid intestine, and they will have a combination effect that is complementary. So if it's statin lowers by 30-40% and an injectables by 50%, and if the person needs additional one, then actually you can have a lowering LDL by 70-90%. As with all medications, they all come with a side effect profile. Every medicine will always has a risk of side effect. And that risk is a bit more in some older drugs. So statin is very notorious for having side effect of muscle pain. This happens in about 5% of people. So, but because statin is the most widely prescribed lipid-lowering agent in the entire world, so millions of people are on it every single day. That's why there's a lot of reports in the news and things like that. They're concerned of muscle pain. It is true, it can cause muscle pain, but sometimes we're not too sure whether or not it is the idea of taking statin or is it really the statin cause muscle pain. Nevertheless, if they have very bad muscle pain, you can't take statin. The good news is you have other agents to try. Very rarely, statin causes liver injury, 1 in 10,000. It can happen. We're often not sure why, but it's something to be concerned also. A majority of people, 95% of people are fine with statin and they can take for the whole life. The injectables, right, which is the evolocumab or the inclisiran, the thing is that very little side effect because they're newer agents. They are actually more stricter criteria to be approved, to be sold. And actually, we don't really have much side effect apart from a bit of redness at the site of injection. Most people don't really have this. So I think the side effect is actually money because it costs roughly about 300 to 500 per month, depending where you buy. Now, ezetimibe, which was in the intestine, can have intestinal side effect, but very rare. So stomach cramps or diarrhea. And also the bowel acid, the problem is it's multiple times a day, cause bloating. People don't often like it, not very palatable, but it's something to consider when nothing really works. So time has passed, 20 years. We have the amazing addition of medicines with ezetimibe injectables on top of statin. But in 2024, the problem is cardiovascular disease, heart attack, and stroke is still the leading cause of death, affecting 1 in 3 people in Singapore. It affects most people around the world. 5 to 10% people cannot tolerate statin, whether one of that 7 different statins that I've showed you. A lot of people cannot tolerate, and 80% of people do not achieve the LDL goals. Maybe because they are not compliant, or maybe because they don't like the idea of daily tablets. There are many reasons. And one of this person, for example, is Mr. Ouch. For PDPA reason, let's not say his name. So he has a lot of pain. 45-year-old man whose favorite pastime is golf, cycling, and walking. So he cannot really accept having a lot of pain from statins. He has hypercholesterolemia. In other words, he has high LDL cholesterol. And he was referred to see a doctor, which is me, because he had very bad muscle pain. So let's see here, right? Look at millimoles here. So I put in the red zone here is what's considered high. So his LDL was very high at 6 initially. He tried diet and exercise, which was the correct thing to do. It did come down, right? But he couldn't really sustain. So therefore, the doctor did the correct thing, which is give him statins. He tried 1, after 2nd, after 3rd, but with every statin, it was just so painful. And then by 2010, ezetimibe came along, he could try that. But because it's a relatively weak agent of 15-25% lowering, he still can't maintain his LDL. And then he tried many other things, fish oil, over-the-counter supplements. Nothing really worked. And by then, he's already in the 50s and he has a triple vessel disease. So I advised him, take injectable. It doesn't affect your muscle, liver. It doesn't cause you any pain, except the 2 weekly injections. And then he did that. LDL is very good and he is fine. Talking about Titanic and iceberg, right? We need to think about actually what really caused that lipid particles to accumulate and what are the major lipid particles. So we mentioned there's LDL, there's medication to lower that, but of course there's addition to your diet, right? And then there's LPA, which we'll talk on another day. Recently we had a LPA awareness day, and I hope we will have more of this in future. And then also triglyceride. But let's talk about triglyceride in the last few minutes because among these 3 conditions, it's extremely painful. Now, Miss Out, right? So she's a 30-year-old female, sudden onset severe tummy pain, usually in the front area. It can radiate to the back. That's where the pancreas sits. And this is because she has very high triglyceride, 25 millimole per liter. So what is normal is less than 2 or 1.7. What is high is anything before more than 5. It can go as high as possible. We even had patients with 100 triglyceride level. And what's important for you to remember is triglyceride is very inflammatory. It destroys the pancreas and hence the severe pain. And the pancreas sits right here behind the stomach. So pancreas being inflamed, in other words, it's called pancreatitis. So any itis behind it just means inflammation. This is because of high triglycerides. And to push it down, this is a patient requiring admission, and we need to have a lot of medication, fibrate statin, fish oil, intravenous insulin, and lots of fluids. I want to show you and scare you before you eat your next char kway teow, is that, you see this very high amount of fat, light-looking yellowish stuff. This is from the blood. So we take blood and we let it sit there. The triglyceride will coagulate, and this is how it looks like. This can be really toxic to our pancreas, and hence they cause a lot of pain, and it can lead to permanent diabetes. And then this patient also has eruptive xanthomata. That means that it comes out in the skin and also into the eye. And how to lower triglyceride, right? So what spikes it? So is high oily food, is diabetes, is high sugar, obesity, so having too much excess fat, and also alcohol. So we know if that's bad, then we do the contrary. So we control diet, no alcohol, control sugar, excess weight. Statins also help to lower triglycerides by 30 to 40%. Apart from lowering LDL, it lowers triglyceride. Fibrates also will help. And then there's also some fish oil. So 2024, which means 2025 is coming. What is in the horizon? Actually, in other countries, and not in Singapore, there are 2 new agents that can lower lipids. So it's bempedoic acid, it's a tablet a day, and this one does not cause muscle pain. So actually it works in the liver also, but it doesn't cause muscle pain, unlike statin. Evinacumab is as an intravenous, very expensive medicine, but it's available in some countries where they can lower very high LDL for people who have this genetic condition called familial hypercholesterolemia, lifelong high LDL. And the good news is this helps, in addition to all the ones I have mentioned, to lower the LDL further. So this is to show you, right, the amount of effort that the whole world of medical science has put in. The studies after studies, and hundreds of thousands of people have, participated in studies and to find the medications to lower our lipids. And in the small box on the right here are new drugs that is coming out, which will be effective and safe. So in summary, most medications work by increasing the clearance of the bad lipids, which carry cholesterol. The combination therapy works well. Doctor will decide, whether you need this or that, and depending on your level and your risk. But medications only work if we take them. Otherwise, it will not work. And I really like to end this, right, with this, rather than a celebratory, fireworks in 2024. I really like this picture from the newspaper in The Edge. And I saw this and said, yeah, this is how we are doing, right? We are working towards better year. More effective and safe medications will come. And also just to end off, there will be another talk in case I cannot answer your questions today about lipids and LPA, which is organized by the National Library. And you can go online to sign up if you like on the 10th of July. Thank you for your time.
Thank you, Dr. Loh. That's a very extremely informative session on the history of medications for the management of high cholesterol. I think maybe just to say a little bit is that statins and ezetimibe has been one of the base medications for the management of cholesterol, and that still remains as one of the base for a majority of people. But the advent of of injectables, these anti-PCSK9 medications have bring light for many patients who have, especially those who are higher risk, like those who had a heart attack before, and they need much lower LDL levels. Those medications have bring hope to those patients, and also those who cannot tolerate the usual medicines of statins. So we look forward to more exciting medications out there that may help people who are not served.